It's the AEMT lecture series. Welcome back. This will be video number 2 for chapter 20, and it's GI emergencies. So welcome back. We'll pick up where we left off, and that's going to be here at the large intestine. So once it reaches the large intestine, it's the function of the large intestine is just to basically absorb water. Everything has kind of been done to this point. All the minerals and things like that got taken out in the small intestine, and now we're in the large intestine. They say it's a site of bacterial digestion, meaning that's where you hear folks say, well, that's where the good bacteria is. And and that is where you would locate that. The spleen. So the spleen is not part of the digestive system. Okay, the spleen is associated with the lymphatic system, which deals with immunity, things like that. It just happens to be in the abdominal area, hanging out with the digestive folks, and it gets lumped in, but it's not. It's lymphatic. It aids in the development of red blood cells. And produces antibodies. And then it leads us to the male and female reproductive organs found in the abdominal area. In the female, in the lower part of the abdominal pelvic area, you have the ovaries, fallopian tubes, the uterus, the cervix, the vagina, and of course the males, the testicles, epididymis, the vasa differential, seminal vesicle, prostate gland, and the penis. The urinary system. So here we are at the urinary system. The primary function of the urinary system is to remove waste. Okay, but it also works with acid base. Okay, so we know this from previous chapters. The kidneys are the late to get into the game of acid base, but they can retain bicarb, right, to help with that. The parts of the kidneys, well, we know that in the kidneys you have the bladder, and the function of the bladder is to store urine, right? The urine has to get there to the bladder, and that gets there through the ureters, and from the bladder outside of the body, it travels through the urethra. Okay. Again, let's go. Main functions, of course, besides moving waste, regulates electrolytes, water content, and we've already talked about the acids of the blood. Removes that metabolic waste that the liver clears up, okay, and drug metabolic waste as well. Kidneys produce hormones to help in the regeneration of red blood cells. And then so we see here in this drawing on the left, the renal cortex, and that's where urine is made. Let's see if there's anything else in here. There is. When the kidneys fail to lose their ability to function, urine is going to back up, right? And so we call it urea. Okay, and what happens is it ends up being absorbed into the blood. Okay, and that leads to a condition called uremia. All right, let's talk about the acute abdomen. So acute abdomen just means it's I'm feeling great, everything's going good, and bam, I get hit with abdominal pain. So it's acute pain felt and the abdomen. And then they talk about peritonitis, right? And so we can break the word down and look and see it has itis, so we know that there's infection involved. The peritoneum is actually the lining of the abdominal cavity. And so peritonitis can be associated with infection, abdominal wounds, blunt injury. That's just like the slide says. I hate reading from the slide. But just understand it's more associated with infection. Okay. So then we talk about the peritoneum and kind of breaking it down. And the peritoneum consists of two membranes. Okay. Two membranes. We had the visceral and the parietal. Okay. So that's the two membranes, and the visceral actually covers the abdominal organs, and the parietal is more attached to the abdominal wall. Now they're going to talk about we're going to talk about pain and how the central nervous system perceives that pain. And so you'll hear sometimes people refer to abdominal pain as organ pain, right? And when they say that, what they're really talking about is that visceral pain, because it's the visceral part of that peritoneum that covers those organs. And then they talk about the parietal pain. I don't want you guys to get too caught up on that, because we'll talk about deferred pain here in a minute and how all that associates. But when you're associating pain and central nervous system between visceral and parietal, if we had another 6 months, we would talk about how the effexor nervous system works. It's a whole different branch of the nervous system. It's called the gut nervous system, and that's kind of slang for it. But we really don't need to go there, because I'm telling you, I was trying to even figure out a way maybe I could mention it and just kind of go over it a little bit, but it's so complicated and complex that it's hard to put your head around it. It's just, I think the best way to look at this is there's organ pain in the abdominal organs, there's organ pain, and then there's everything else, right? And we'll get to the deferred pain in a second, but it tells you that the parietal peritoneum, again, that's going to line the abdominal cavity, and visceral covers the organs. And visceral pain, remember, that's going to be associated with the organs, occurs when receptors are stimulated. Now, these receptors are called stretch receptors. Just like the lungs have stretch receptors to protect it from overfilling, the abdominal organs have these stretch receptors, right? And when they stretch, it kind of can if they stretch too much, that's what brings on that pain. And so and that's associated with the organs. And when we talk about that organ pain, visceral pain, it's usually very identifiable. It's very low. You can locate it. I can, if I have liver pain, my liver's hurting. When I palpate over that liver, you're going to feel that pain. Exactly, it's right there. But non-organ pain, or the parietal pain, it's much more complicated to track it down, because parietal pain works off a different branch of the central nervous system. It's reporting down, using nerves that other organs, or not other organs, but other areas of the abdominal, they actually share pain pathways. And so when you share in pain pathways with somebody else, the message gets complicated, and that's what happens. And so here we have referred pain, and that's what I was talking about earlier. Let's say, for instance, I have gallstones in this gallbladder, and I'm having pain from that. Well, that pain may be up here in my shoulder, or it may be, right there in that right upper quadrant, and may be radiating to that right shoulder, or it may just be right shoulder. It just depends on the nerve pathways and how they respond. And so it's pretty interesting how it works. And then we're back at peritonitis. We're going to continue talking about it. And they say it typically causes ileus. And so what ileus is basically is when muscles in the organs, and they stop moving that food and that process through, meaning the bile stops moving around, or in your stomach, the contents are just sitting there. They're not being moved from the stomach to the small intestine, and they're not being moved because there's not that rhythm type motion happening. And so what happens? Well, it just sits there, and when it sits there, it can lead to emesis, which is a small word for vomiting. And so that's what's happening there. So the book goes out of the way to say that we can associate loss of body fluids and or we could see patients experiencing hypovolemic shock from peritonitis. And yeah, definitely happens, but not every abdominal pain does that happen. I would say most don't. But we have to, it can happen, especially with different circumstances, like maybe a peptic ulcer that's bleeding, or maybe you have a small intestine that has a blockage and it's perforated, it's open, so that's where you start getting into hypovolemic problems. But that's the reason why the abdominal, it's so hard to diagnose, because 8 out of 10 maybe same pain, same type of presentation, and have no hypovolemic shock, and then you get the 20% that do. So it's always been difficult when you have someone with acute abdominal pain. But if that happens, it's if it's not hemorrhaging, if it's not like a GI bleed and we're just losing plasma, not an easy fix, but yeah, a lot easier than hanging blood. And we can put a saline bolus and fix a lot of that. Then we talk about diverticulitis and cholecystitis. Okay, so diverticulitis, these pockets form inside on the very inside of the colon. Okay, and these pockets are called diverticuli. Okay, diverticuli. Now, you can imagine when you have, you have stool passing through that colon, and then we already have that good bacteria there. Sometimes that good bacteria can cause that diverticuli to become infected, and when it does, it's called diverticulitis. Either way, though, that's how that happens. You have multiple small little pockets, and they get infected. And cholecystitis is an inflammation surrounding the gallbladder. Sometimes that's related to gallstones, sometimes not. It just depends. We talk about fever here, and it says fever may or may not be present, and it's true. I mean, if depends on what stage of the peritonitis you're in. You could be in the beginning stages of the inflammatory process and not have a fever at all, have lots of pain but no fever. Or you could be on that back end of it and you could have a fever. It's not a guarantee, though, that you're going to have either one. They compare that, though, to like an appendicitis. And again, they may have normal temps unless the appendix has ruptured, right? And if that has happened, you can imagine you have all this bad stuff floating around inside the free fluid area of the abdominal cavity, and that's not good. We have urinary tract infections, acute kidney injuries, things like that to talk about. And I wish I could make that easier for you, but I can't because their symptoms are all over the place too. The only thing that seems to kind of go with the urinary tract infections, and this is probably not even in the book, it seems to be the state where anyone over the age of 50, they usually have a pretty prominent altered mental status secondary to a urinary tract infection. And sometimes those become a septic type infection as well. The table in your book is very informative. I would know this stuff. It's in this table. I know every bit of it because if you do, it's going to take you a long ways. It'll help you on the test. It'll help you for registry, and it'll help you be a better clinician. So what causes the acute abdomen? Yeah, lots of things can cause an acute abdomen, but the book kind of narrows it down to the peritoneal fluid. That fluid's there to kind of keep the organs moist and reduce that friction in between the organs when they move around. If that fluid comes in contact with something like if you had appendicitis and the appendix actually ruptured, it's going to mix with that fluid, and it could be a nasty infection. And that would definitely be an acute secondary, not secondary, it'd be an acute abdomen for sure. Anything that's not supposed to be in the abdomen that ends up there is usually a bad place for infection. It's the reason why gunshot wounds are so deadly when they're in the abdomen. All right, let's talk about the gastrointestinal hemorrhage, GI bleed, okay? It's a common call for us in the pre-hospital setting. It comes from it can be a chronic problem, it can be an acute problem. It just depends. Usually if they have had one GI bleed, they're going to have another one. And it can be from those ulcers developing on the inside of the stomach or small intestine or colon. There are two different types. There's an upper GI bleed and a lower GI bleed. When we're considering an upper GI bleed, we're talking about the tract that spans from the esophagus to the upper part of the small intestine. Okay, and so an upper GI bleed, we could be looking at esophagitis, a big one I talked about earlier, esophageal varices, right? So those are two. They use a definition here, hematemesis, okay, that means vomiting blood, and that's frequently seen in patients with upper GI bleeds. And then we talk about the lower GI bleeds, the upper part of the lower GI bleeds is the upper part of the small intestine to the anus. Okay, and some causes of that usually bowel inflammation, diverticulitis, cancer, and even hemorrhoids can cause some blood loss there too. We use another definition called melena, and that's dark tarry stools. Okay, and that's because that blood is mixing in with the stool and it looks really black and tarry. Esophagitis, so esophagus and itis, inflammation of the esophagus. That can be brought on by something called reflux. People who have a constant acid indigestion. And what happens is that acid is coming back up into the esophagus. And that's causing that esophagus to ulcerate and become very painful and can cause bleeding. And then we have some causes, from some of that. It can be radiation treatment or chemotherapy. Some of those processes weakens those areas. Okay, I already talked about this. I mentioned GERD here, gastroesophageal reflux disease, and so GERD is what's used all over the place, and that's what I was talking about earlier. It's associated with that stomach acid coming back up into the esophagus. Peptic ulcers. So that's where the peptic ulcers, there's a lot of acid there in the stomach, and it's just way too acidic sometimes, and it starts actually eating into the organ. And sometimes alcohol disease and smoking can increase your chances for these things. So peptic ulcer disease, that affects men and women pretty much 50-50 on this. Nausea, vomiting, usually it's big, pretty common symptoms. And then there could be bleeding. You could have, that sort of thing, vomiting blood. And what stops that is simply reducing the amount of acid content in the stomach. So we're going to give some medicines that's going to do that. It's going to reduce a lot of that acid content. A Mallory-Weiss tear. This is an actual tear in the junction between the esophagus and the stomach. Okay, that's a bad day, because just imagine how vascular that is. Severe bleeding and death from hypovolemia. And so we see alcoholism, a lot of eating disorders could cause this. You can see this in women who are pregnant and just continuously vomit throughout their pregnancy. The Boerhaave Syndrome, it's very similar to the Mallory-Weiss. It's a longitudinal tear, of the esophagus. And this is going to create a passage for blood and air. This one's going to be more associated with men than women. And I mentioned esophageal varices earlier. Signs from secondary to liver disease because of where the veins are coming from, right? It's that portal vein, backs up, and blood backing up from the portal vein stretches back to the esophagus. Big association with this and alcoholism. Right. Let's see here. Other initially patients of liver disease. These folks are very fatigued, weight loss, but a big one's jaundice. That they have that yellow jaundice-looking color. They don't want to eat, so they're going to be very frail. The rapid weight loss. So when you're dealing with esophageal varices, what you'll see, sudden onset of discomfort in the epigastric area. Okay, right there just below your sternum where that xiphoid process is, that's the epigastric area. Vomiting of copious amounts of bright red blood, major hypotension, signs of shock. So blood loss, big one there. Excuse me. Then we have hemorrhoids here. You're like a hemorrhoid to me, people say. So yeah, it creates swelling and inflammation right at the anus. Sometimes you can have some. Let's say it's a little sometimes moderate bleeding. It normally doesn't turn into a hypotensive crisis. It's usually bright red blood. And then we have gallstones, and these are bad days right here. Gallstones are just they're painful. They're really hard on people. It's usually not life-threatening, but you'll wish you were dead. So remember what the gallbladder does. It stores that bile, and if that outlet from that bile duct gets blocked, that's usually blocked from a stone. It can cause severe pain, and it's severe pain, nausea, vomiting, very malice, just a bad day. Sometimes gallbladders can rupture, and it's kind of like the appendix when it ruptures. Major septic problem. Usually, this does appear after eating some type of fatty meal, because bile breaks down fat, and there's nothing around to break. Well, there's some around, but that bile can't escape, and the fat's nothing to break it down. Nausea, vomiting, indigestion, it says. It's just, it's pretty rough for folks. Pancreatitis. So, pancreatitis is another kind of very miserable type disease process. Remember, the pancreas helps form the digestive juices, helps to form insulin. Pretty important deal, but nausea, vomiting, the whole 9 yards. Very similar to a gallstone type symptoms. These patients do seem to have fevers. They do seem to be tachycardic, and they do respond. It seems like they are very, at times, hypovolemic. Your appendix. Yeah, so symptoms are all over the place, but normally you're looking at an early morning onset of abdominal pain that generates around the navel. Okay, and as the day goes on, the pain seems to start becoming more associated to the right lower quadrant, and that seems to be the pattern. Sometimes you have nausea, vomiting, fever, chills, but this depends on where that inflammation process with the appendix is, how swollen the appendix is. And sometimes people have really bad appendix and they don't know it, and the body seems to take care of it and it kind of goes away. And it can come back, sometimes it doesn't, but then you have some appendix that happens and they rupture, or hopefully they catch it before it ruptures. Then gastroenteritis. So this is a diagnosis that's really put on folks when you really just can't find out what's wrong. You got an abdominal pain. They've had every test in the world and nothing kind of shows up. So these can be caused by viral or bacterial organisms. And again, nausea, vomiting, anywhere abdominal pain, basically. Then we have the diverticulitis. And so diverticulitis is associated with diet, usually. It can be associated with foods like corn, cabbage, and that sort of thing. And so somebody might be, all of a sudden on a cabbage diet, and they've been eating cabbage now for 8 days, and now they're presenting with, severe lower abdominal pain. And so that's kind of where that kind of leads you to a diverticulitis type diagnosis. Sometimes you can associate this with constipation. So the main symptom here is abdominal pain, and it usually is left-sided abdominal pain and usually left lower quadrant abdominal pain. These patients do seem to have fevers more often than not, body aches, chills, just generally just not feeling well. I would say that these patients, just in my opinion only, no science to back it up, are not as miserable as your gallbladder patients are or your pancreatitis patients are, but they are pretty miserable. And then we have ulcerative colitis. All right, and so this is going to be associated with the colon. This doesn't, they compare it to Crohn's disease, but it's not, because Crohn's disease it's kind of patchy. Patchy, and what it means, like you have a patch of maybe a bacterial type problem going on in different patches. It's not like that. This is going to occur more often in men than women. Usually a strong family history of this. And abdominal pain, but add a little joint pain. Like that's kind of different with this, and sometimes skin lesions. And then irritable bowel syndrome is a very common disease that we see out there all the time. These patients are usually, like hypersensitive type patients with their bowels. It's an unclear pathophysiology wise. It's kind of still unclear. You have some patients that will have diarrhea, some patients that will have constipation with this. This is one of those disease processes that can be triggered by stress. Okay, it can be triggered by diet. Okay, lots of patients who are lactate intolerant can develop IBS, and maybe they didn't know, and they've had some milk or something. It can set IBS off. Crohn's disease. So this is similar to the ulcerative colitis, but this involves the whole GI tract. 15 to 35 years of age. Usually family history is, family history follows Crohn's disease. And this is where you have white blood cells that are actually attacking the layers of the GI tract. And then we have the urinary tract infections, urinary system here. These can range from mild to severe. And symptoms, like I said, are all over the place. You can have somebody younger having a little bit of back pain. You can have somebody who's 70 or 80 years old suffering a major medical emergency from a UTI. And two, you may not get the report of painful urination because they may not have it in the older folks, but the younger folks may. And then the common symptoms. So painful urination, frequency. So somebody's going to the bathroom all the time, and then they get there and they can only void a little bit. Okay? Burning type pain. The urine can be cloudy, may have a foul odor. And then we have kidney stones here. Kidney stones, extremely painful. And there's there's no real reason why yet. I mean, people say, well, it's a buildup of calcium. Okay, not completely confirmed yet. Your book says salts and uric acid crystallizes in the urine. But either way, kidney stones are hard. They're very painful again. If they're larger than 5 millimeters, then it's either surgery or other means to remove that, like blasting, stuff like that. The most common is the calcium stone. This is definitely more frequent in men than women, although I've seen women with this problem. It's not uncommon for women, but it's just more common for men. Then we have acute kidney injury. This is like a sudden decrease in kidney filtration. They say it's reversible if diagnosed and treated early. This is definitely not the type that's associated with diabetes. Then we have chronic kidney disease. This is probably the one that you can associate with like diabetes and hypertension. This can be brought on by some certain type of congenital disorders, like strep throat. Pretty interesting. Okay. So the nephrons of the kidney can become damaged and cease to function, and that's where urine is produced. So that's the problem. You start scarring some of that tissue inside the nephrons. Then you end up having your waste products build up, and then you see this with folks who have uncontrolled hypertension, congestive heart failure. Okay, a lot of times you can develop congestive heart failure secondary to the kidneys not working. and a whole host of signs and symptoms. End-stage renal disease, these are the folks who go to dialysis 3 times a week. And it's usually a progression from chronic renal disease. Okay, so end stage means if it wasn't for dialysis, they would die. These folks usually, if you're dealing with an end stage renal patient, these folks already know kind of what got them there. And they're clear, and the signs and symptoms around it, they know. And then we have reproductive organ problems. So don't ever take this lightly. There's been a many EMS lawsuits because somebody called EMS and their symptoms were not taken serious enough, and it involved the reproductive systems, and they couldn't have kids anymore. So you can imagine, I mean, that when you can't reproduce and you're young, that's a terrible thing to hear. It really is. Pelvic inflammatory disease. This is an infection usually of the fallopian tube or surrounding tissue. Lower abdominal pain, pelvic type pain, fevers sometimes, and it can be from mild to a high fever depending on how bad that inflammation, that pelvic inflammatory has come along. Ectopic pregnancy is a killer. That's the reason why in EMS, even inside the ER, female childbearing age with abdominal pain is ectopic pregnancy until proven otherwise, period. Because you can't go wrong with going with the worst, okay? And so this is when that fertilized egg gets stuck in the fallopian tube. See, the egg and sperm meet inside the fallopian tube, but usually that migrates out of the fallopian tube, and then the egg actually attaches to the uterus. Well, when it gets stuck in the fallopian tube, the egg starts growing and ends up rupturing the fallopian tube. And when it does, it's very vascular, and it's a really large hemorrhage loss, and it's life-threatening. And it's absolutely hard to diagnose in the pre-hospital setting. It's hard to diagnose in the hospital setting. If the patient doesn't get the appropriate test, it can be missed. And there's been many I've seen rushed off to surgery that I didn't suspect that was going to happen. I didn't suspect the patient was going to be ectopic, even though I know that suspect it. And I do suspect it, but I'm shocked by it sometimes. 1 to 2% of all pregnancies are ectopic. And that's quite a number if you think about 2% of all pregnant females ends up being ectopic. The fallopian tube can support that egg usually 6 to 8 weeks before the fallopian tube is going to rupture. And so, bad thing is, 6 to 8 weeks pregnant, the person may not know they're pregnant yet. They may have an idea they're pregnant, but they don't know. And then we have the physiology of the genital tract. We're talking about the prostate. Miserable. Guys come into the ER, they haven't been able to urinate for close to 24 hours. And when you don't care that someone's going to insert a urinary catheter into a guy, then you know you're hurting. and you know how bad that must feel. So these happen to guys usually over, I was going to say 50. I think the book says 60. And they just have difficulty, usually starts off, they have a difficulty getting urine to flow. And then they can get some out, and then it gets worse and worse and worse. Here's one. Testicular torsion. And these are easy to miss in kids, especially small children, 1, 2, 3 years old. Okay. And these can be bad because you'll get the call, and the complaint may be, my baby won't stop crying. And so you're thinking, this is crap. It's 2 a.m. and you can't get your kid to sleep. Feed it. But there's a question you can ask that can see, moms and dads, they get tore up on this. Kid's been crying now for 4.5 hours, 5 hours, and it's 1 o'clock in the morning, and you don't know what to do. So you call 911. So you're frazzled. You're very frazzled. And so all you know is the kid's crying, and it'll stop crying out of exhaustion, and 10 minutes later it's crying again, and it cries. But there's one question you can ask mom or dad to see, and you can say, look, is the baby's crying any different? What's different about the baby's crying today as opposed to any other day? Or is it different? And if they say, oh yeah, this cry is completely different, they may not even, it may not even hit them till you ask that question. So ask the question and see what they say. If they look at you and go, yes, my God, this is so different than any other time I've ever, known in the past year or two, then take that serious. Take that seriously and transport that kid. Don't blow that one off. Don't think it's just because the kid's hungry or wet. It's going to be something different. If they tell you that cry sounds different, react to that. So here we talk about the aorta and the abdominal aorta, large organ coming off the aorta of the heart, right? Large. And what happens is the patients with history of hypertension, uncontrolled at times, has weakened that aorta. Remember, I talk about the circulatory system being like a circuit, and it's used to a certain amount of pressure. But once that pressure starts getting high and uncontrolled at times, it takes a toll on the body, and the aorta pays the price. It stretches out and it dilates. And sometimes it dilates and forms a weak area inside the aorta. I'm sorry, I'm just looking at my computer. I'm hoping it doesn't crash. And it can cause an aortic aneurysm. Now, so you're looking for somebody over 50, maybe has a history of hypertension, or has hypertension and didn't know it, maybe. It could be something like that. I've heard people say the complaint sometimes is, it feels like something's tearing, but I've never heard that complaint, but I've had a couple, and the complaints that were presented to me was severe lower back pain and leg pain. Severe lower back pain and leg pain. It's referred pain. It's a non-organ type pain, and it's sharing those nerve pathways, and so you could get something weird like that. So you get somebody who's in severe pain, and they're complaining of severe lower back pelvic type pain, and they can't, have you lifted anything? No. Have you done anything? Any trauma? You start ruling this stuff out, and you can look and tell they're really hurting, and so that's when you need to start queuing in. You may have a patient who has blood pressure is hypotensive, but you may not. That may be compensating. So That's why it's such a life-threatening deal, and that's why so many people die from it, because you can't pinpoint it. You can't say it hurts right here. And then we have the hernias, and they usually, hernia is a protrusion of the organ or tissue through a hole or opening into the body cavity, right? And so in men, abdominal navel type hernias are pretty common type hernia. If you get to them soon enough, they can actually push the hernia back in, reducing the hernia. They don't all need surgery, but sometimes they do. Sometimes they will present with a mass. Sometimes you can't feel it. Okay, that's going to be all for this chapter. The rest of this chapter is seeing size up and treatment. I think it's all pretty self-explanatory. Run into any problems, let me know so we can get on it, okay? Enjoyed it and look forward to talking to you in the next chapter.